So we have Mr. Latif, who is a 64-year-old gentleman, and he had a surgery for hard palate squamous cell carcinoma, and we're going to review the histopathology today. Of note, his CT scan that was done as baseline showed a right cervical lymphadenopathy.
So the surgical specimen contained a 2 centimeter squamous cell carcinoma mass with a depth of invasion of 6 millimeter. Out of 3 lymph nodes in the sample, only 1 had invasive carcinoma. The margins are all clear and no lymphovascular invasion or any other risk factors.
Well, thank you, Dr. Mahdi, and I'm going to come back to you for further elaboration on the pathological staging, but I must mention that the patient has a number of comorbidities. She is diabetic, hypertensive, and she has coronary artery disease, and she is not keen on radiotherapy as she is extremely worried about possible side effects.
Oral cavity tumors are cancers that occur in the buccal mucosa, floor of the mouth, hard palate, retromolar trigone, alveolar ridge, or anterior tongue. Given that the patient has no adverse features, adjuvant radiotherapy in this situation would be considered optional. But given the unclear benefit and the patient's reluctance, observation would also be an accepted approach. The adverse pathological features in this situation include extracapsular spread, positive margins, perinuclear and lymphovascular invasion, N2, N3 nodal disease, and T3, T4 primary. And the presence of any of these features would be an indication for adjuvant radiation or even possibly adjuvant chemoradiotherapy.
Mr. Hazim, who is a 55-year-old, presented with a soft palate mass, and we did a biopsy for him which confirmed the squamous cell carcinoma. We're here today to review the PET-CT.
Yes, indeed. There is a 3 centimeter FDG avid mass localized to the right of palate, consistent with the primary cancer. No lymph node metastases or any other signs of distant metastases.
Well, thank you, Dr. Mahdi. Of note, the immunohistochemistry for HBV showed a B16 negative. So what would be the next step in our management?
Oncology.
Patients with early stage head and neck squamous cell carcinomas can be offered single modality therapy. This patient has a cancer of the oropharynx, which is defined as a tumor of the base of the tongue, tonsil, posterior pharyngeal wall, or soft palate. As this mass is more than 2 centimeters but less than 4 centimeters in size, it is a T2 disease. The nodal staging is N0, and as this is HPV negative oropharyngeal cancer, the overall staging is stage 1. In this setting, either definitive radiotherapy or transoral open resection of the primary plus minus head and neck dissection can both be considered.
Mr. Ali, I have now received the results of your lymph node biopsy, and I'm afraid it might be disturbing news.
Oh dear, doctor, don't tell me that the tumor is back.
I'm afraid so. The biopsy actually showed squamous cell carcinoma, which is the same cancer that was treated in your tonsils about 6 months back.
But doctor, this lymph node, I was told that it was there before. It was treated with radiotherapy. Is that not true?
Well, correct, actually. This lymph node was covered in the radiation field when you received the chemoradiotherapy treatment. But despite this setback, the PET-CT is still showing that this is the only source of disease as of now, and I think we have options to give you for treatment.
Local region failure rates can be found in over 35% of head and neck cancers, and surgical resection for local region relapse is recommended in fit patients with no distal disease. Following surgery, adjuvant radiation can be given to radiotherapy naive patients who have risk factors. These procedures can be curative in some patients. PET avidity can be due to radiation inflammation. Thus, waiting for at least 12 weeks post-radiotherapy prior to performing a PET-CT scan would be recommended. However, this patient had the treatment 6 months ago, hence the current PET findings are unlikely to be radiation related. Proton beam therapy is an advanced form of radiotherapy with radiation treatment being delivered by accelerated proton beams rather than the X-rays. A proton beam delivers some radiation to healthy tissue in reaching the tumor, but very little beyond the edge of the tumor. Proton beam therapy is currently being used increasingly to treat children with cancers.
Dr. Ahmed, I went to see Mrs. Lee. You remember the 54 Chinese lady she's now in the surgical ward and actually was diagnosed with a metastatic squamous cell carcinoma, possibly from a nasopharyngeal origin. She was seen by the ENT specialist and they did an exam and we did also an MRI of the head and a PET-CT. They're going to present her in the MDT and I was wondering if anything else needs to be done.
I think we ought to discuss her imaging at the MDT, but in the meanwhile, they could ask for a specific virus that does strongly correlate with nasopharyngeal carcinoma. You know what this virus is, Ali?
The association of nasopharyngeal cancer with Epstein-Barr virus has been firmly established since 1973. However, the evidence indicating a role of this virus in the pathogenesis of NPC is still largely circumstantial and controversial. Recent studies have found that squamous cell NPCs and non-keratinizing NPCs vary with regard to their ABV association. Squamous cell NPCs may be ABV negative and other factors such as smoking or HPV infection might be involved in the pathogenesis. By contrast, non-keratinizing NPCs are almost always ABV positive. ABV-associated NPC has been proposed as a promising target for virus-specific immunotherapy, but this is not yet an established treatment. If a patient has an occult primary cancer, squamous cell, adenocarcinoma, anaplastic or undifferentiated in the head and neck area, one could consider evaluating to see if the tumor stands for either HPV or ABV, as this can inform if the primary is from the head and neck or from somewhere else.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share and subscribe, and don't forget to join us every Thursday 5 p.m. Greenwich time.